Welcome to whoever is going to view this. This is a sort of public service by Albright College to try to help give some background and some information about the coronavirus and the disease that is currently inundating the world. So a little bit about myself. My name is Adam Hershberger. I am in my 7th year at Albright College in the biology department. And why am I here? Well, it turns out that Albright College has a resident virology instructor and researcher. The provost and acting president, Dr. Karen Campbell, asked us if we would put together a video resource that provides some information for the public and for people on campus. I teach in, like I said, the biology department. I teach courses all the way from basically freshman year all the way through to seniors. So I teach like intro to genetics, virology, immunology, microbiology, and an advanced course on genetics. So I really enjoy it, and I teach a lot of students that are going off to become dentists or physician assistants, doctors, nurses, etc. So it's a very rewarding job, and I like it a lot. Okay, so that's a little intro about myself, and now I'll turn it over to my colleague over here, Dr. Williamson. He can introduce himself.
Thanks, Adam. So I'm the college physician here at Albright. I've been here for about 6 years. I'm a board certified pediatrician, actually, with a specialty in sports medicine. Early on, I came here to do a little extra work with the athletes, and along with seeing students for acute illnesses and injuries in the health center. I still work part-time in my primary care office down in Pottstown, and I'm here today as the Albright College physician, though, not in my other capacity. I'm kind of excited about this opportunity. I get to ask Adam a few questions that I have about this virus. The pandemic has been evolving rapidly, and the interesting part is that everything you hear one week changes within a couple days. I watched a podcast yesterday, and one of the experts down in Texas in infectious disease started out by saying, "What you hear today will probably be out of date tomorrow." Yeah. So it's we're going to have a lot of information rolling in on this, really for probably years to come.
Right. Okay. So what we thought we'd do today, for those of you listening, is start with a background about the virus itself, and then we would move into a little bit about some of the common signs and symptoms and the disease course. So in terms of viruses, okay, so viruses are interesting because they're not really thought of as being alive, yet you could certainly consider them sort of maybe an organism or a biological entity. They require another cell in order to produce offspring. So they're what's called an obligate parasite. They essentially take over cells to make the cell make more viruses. And the primary goal of any virus, whether it's coronavirus or the common cold virus, is to replicate and transmit. Their primary goal is to spread. And so they work to try to achieve that end of spread. And there's many and varied ways that viruses do that. So in terms of this particular virus, so it's rather interesting because it has an RNA genome. So if you look at around the world in different forms of life, whether it's a fungus or the human body, bacteria, okay, basically any living thing that you can see, a plant, it has DNA as its inherited genetic material, right? The genome that it passes on from cell to cell, the genome is DNA. So viruses are unique in that some viruses have their genome encoded as RNA. And so they're very unique in that sense. So for example, influenza virus, Ebola virus, the common cold virus, and coronavirus, they all have an RNA genome. And so this particular virus, it encodes it as RNA, and that's what gets passed on from various to their viral offspring. Okay, so it's an RNA virus, and surrounding the outside of the virus is a phospholipid bilayer, which is called an envelope, and then sticking out of that envelope are these spikes, and they're literally called the spike protein, or the S protein for short. And these spike proteins are responsible for binding to proteins on host cells. Those are called receptors. And that spike protein on the virus and the receptor on the host cell, it's kind of like a lock and key. It's a very specific interaction. And when it gets to the right receptor, the appropriate receptor, that allows the virus to then enter that cell and to begin the replication process. From what I have read and understood about this particular virus, it seems to be able to replicate in the airway epithelium, in the lungs, and also in cells derived from the intestine as well. There is some evidence that it is shed in the feces, as well as being found in the airway. So once it gets inside of cells, it replicates and produces viral offspring. Okay, so I mean, that's just a little bit of background about, viruses and about this particular virus. Josh, can you think of any questions that someone might ask about the virology aspect of it?
Well, I think that's a really good point that you brought up about the fecal spread. That's something that has not been talked about, at least early on in the pandemic. It was recognized several weeks, if not a month or two into the pandemic. And there's evidence that because that's one of the main drivers of why this virus has been able to spread as well, as efficiently as it has. Like you said, it's the virus tries to spread, and this one is doing a really good job of that. And the big focus is on respiratory droplets as far as human to human spread. But the fecal oral transmission is a major driver for this.
Right, and just to add to that, think like daycare setting. Think young kids, right? People not washing their hands. The fecal oral route is a very common way for viruses to spread, as Josh alluded to, and it can lead to contamination of not only your hands but of surfaces. And unfortunately for this particular virus, so I said it has a phospholipid envelope that surrounds it. And what's really interesting is that most of the time, viruses that have that type of envelope tend not to be stable for very long in the environment, like on a surface. That lipid bilayer tends to degrade and break down relatively quickly. So for example, flu is not very stable outside of bodily fluids. HIV, another envelope virus, not very stable in the environment. This particular one, probably because it evolved to at least replicate somewhat in the intestine and pass through the stomach, that envelope has evolved to be somewhat more stable. And so it can survive longer outside the body than other viruses with an envelope. And that, of course, makes it more of a challenge to deal with. I should also mention that, where does corona come from? So I've heard two conflicting stories, and they're probably a little bit both correct. So corona is, I believe, Latin for crown, if I'm not mistaken. And so when people looked under the electron microscope at this virus, they could see on the outside those like spike proteins sticking out away from the surface of the virus itself. And so some people thought it looked like, sort of like the points on like a king's crown. Or I've also heard stories that they thought it looked like the corona of the sun. If you look at some pictures of the sun, and there's these like, sort of wispy things coming off the surface, That's, the corona of the sun. They thought it kind of looked like that. So what's the real story? I have yet to hear a definitive answer, but I've heard, reports that, where does that name come from? So.
So Adam, I see coronaviruses, well, I see the results of coronaviruses in patients all the time. Every winter and spring,
Mhm.
we see common colds, and that's coronavirus. Do you want to talk to us a little bit about the differences between the four strains of coronavirus that I'm used to seeing,
Sure.
and then maybe even the three newer strains?
Right. So, I mean, I'm not an expert on the sort of the medical aspects of those particular like disease courses, but in terms of the virology aspect, yes, there's been coronaviruses that have been spreading among humans for probably thousands of years. Most of those would be considered, I suppose, the seasonal corona that you're referring to. There's a few common strains that circulate on a seasonal basis. My understanding is they tend to be more of like a winter, sort of late, like late winter, early spring type of thing.
And
And
that's right, and they just cause the common cold.
right, and they cause a common cold.
Runny nose, cough, with or without fever,
Very, very mild.
achiness, that kind of stuff sometimes.
Yeah,
And then occasionally the GI symptoms, like you mentioned, the
sure. Yeah, so
diarrhea.
something about coronavirus is they do have this GI component, and some might have a little bit more than others, because there are going to be small differences between these different types of coronas. The the seasonal ones, as you mentioned, are relatively mild. I mean, so the most common cause of the common cold is called called a rhinovirus. That's in the same general family as actually poliovirus. It's called the picornavirus. It's an enterovirus, and that causes about 60% or so of all cases of common cold are these rhinoviruses, and about 30% every year, roughly about 30% are caused by the seasonal coronavirus, causing these common cold-like symptoms. And so some people think that given enough time, that the current virus has the potential to become more like a common cold-like virus as we build up immunity in the population, as we sort of reach a little bit more of a balance between the host and the virus, that it might evolve to become a little bit less pathogenic, meaning disease causing, and will, of course, as a population, build up a little bit more of what's called herd immunity to it. Because my understanding is that the common cold causing coronaviruses, most kids get them before their age, say 3 or 4, right? And they, that can then lead to sort of like not necessarily a lifelong immunity, but the earlier you experience it, probably the less severe the symptomology. But this particular virus, the new virus, it has never been in the human population before. And so when that happens, not all the time, but when that happens, viruses tend to be a little bit more lethal, a little bit more pathogenic upon their first introduction, because they haven't reached that kind of balance point between disease causing and spread, right? So there's a lot of evolutionary concepts involved here that we won't get into today, but it is definitely true that a lot of viruses upon their first introduction do tend to be a little bit more disease causing.
That's a big thing. A theory, at least early on in this, is that maybe that's why kids aren't as affected with this pandemic. That there's some
Sure.
cross immunity, because they've been exposed to 2 or 3 or 4 of the seasonal coronaviruses recently, and their immunity is better than as you get older. With as that immunity wanes, and maybe that's why our elderly population is at such higher risk for severe disease with this, because their body has kind of forgotten about coronaviruses in general.
I think you're right. I also think that potentially just the immune system kind of gets a little exhausted, a little tired, like a lot of things do when people age. So I think it's a combination of that, and just it's called immune senescence, where the immune system just kind of slowly fades a little bit as people get older. So it's probably a combination of both and potentially other factors as well. So just before we move on a little bit more to the clinical aspect, I did want to touch on the name. Okay, so this is, I mean, as someone who's read about virology for a long time, I've never encountered a situation like this where there's really two names, and depending on what article you read or newscast you listen to, they're going to say COVID-19 or potentially SARS-CoV-2. So what's up with that? So the WHO decided to call it COVID-19, and that stands for coronavirus infectious disease. And the 19 is because the first case was in, the latter half of 2019. To me, and I would like your opinion on this, Josh, coronavirus infectious disease, to me, it's rather vague, and it talks about more the clinical side than the actual virology side. I like to use SARS-CoV-2 because that tells me more about the virus, less about, because infectious disease is so kind of vague, right? Whereas SARS, I mean, that literally stands for severe acute respiratory syndrome. So you immediately know something about, the disease, and when people succumb to this, what are they succumbing to? And they're succumbing to acute respiratory distress, and sort of complications of that. And it's highly related. It's in the same family. So it's a beta coronavirus in the same genus as SARS-1 or SARS classic, I guess you would call it now. So, SARS the original. And so, yeah, so SARS, started in the early 2000s in China, and luckily it did not go anywhere, really. It only infected about 8 to 10,000 people worldwide, and it kind of died out. So just briefly on that point, SARS, once you started showing symptoms, that's when you were most contagious. So that really helped in the containment of this disease. Once you showed symptoms, quarantine, and you could limit the spread. This, COVID-19 or SARS-CoV-2, from what I understand, it's spreading even when you're not symptomatic, and that's really hard to control the virus. But just to finish up on the SARS part, so SARS-CoV-2, so it's highly related to SARS classic or SARS-1, and so it's called the ICTV, the International Committee on the Taxonomy of Viruses. They named it ICTV. So the WHO calls it COVID-19, and this ICTV group calls it SARS-CoV-2. I for one prefer to call it SARS-CoV-2, so SARS coronavirus 2. It likely came from a bat, so just like SARS came from a bat, this probably, and some of the sequence data that's starting to come out, it probably came from a bat and then jumped to a human and then spread from there. Okay, so that's a little bit, I'm sure we can get into more virology in another session, but Josh, did you want to start to go through some of the normal signs and symptoms and things like that now?
Sure, Adam. We talked about it a little bit, is that, and you're absolutely right. The hard part with containing this is the fact that a lot of people, and we don't even know how many people, are asymptomatic while they carry the disease, or pre-symptomatic. That's the big thing in the medical literature over the last 2 or 3 weeks, because people are spreading it before they ever even realize they're sick. And then the disease is causing mild symptoms, even in people that are being identified. In about 80%, it's just mild disease. So it's just it's common cold symptoms, or more severe than that. We call it mild disease. I've talked to a couple patients that are going through it and have gone through it, and it's, even though we're considering it mild because they didn't end up in the hospital, it's kind of flu-like symptoms, and you can be sick for a couple weeks with this illness. Now, about 15% of patients are getting severe disease, where they're ending up in the hospital, and the disease course for those patients seem to be that they have their symptoms, and it's that second week where things start to really go downhill for them. And those are the patients that end up in the intensive care units, and then a lot of them needing respiratory support with ventilators. That's what we've been hearing about in the last couple of weeks in the United States is about how many ventilators we have to take care of these patients. And then the fatality rate is questionable. It ranges somewhere between, well, really 2 and 5% for patients that we know about. So what the overall fatality rate is going to be very different, probably less than 1%, but we'll know more about that in the months to come. But yeah, so mild illness, well, what we consider mild illness for a lot of patients, fever, cough, sore throat, and then eventually shortness of breath, which is a little more unique for this illness. A small percentage, probably 2 to 5%, will have diarrhea like we talked about. More common symptoms can be runny nose, muscle aches, those types of general flu-like symptoms.
So Josh, I mean, you hear all the time on the news, like, oh, it might be this, small subset of patients, they have this weird, presentation. What have you heard and what do you make of, so the one that I hear most about is the lack of taste and smell. How common do you think that is, really?
I don't know. That issue, and then which makes me wonder because in some of the countries that were hit early on with this, you hear a lot about healthcare providers being hit hard with this. One of the theories I think that makes a lot of sense is that if you catch a heavy viral load early on, that you're more likely to get sick and have problems. Plus, these unfortunately frontline healthcare workers are run down, tired, stressed. Probably their immune system isn't where we'd like it to be with these exposures. But anyway, early on, healthcare providers, ear, nose, and throat doctors, and ophthalmologists. And so you wonder if there's been, some of those patients made it to the ear, nose, and throat doctors because they were having unusual symptoms of not being able to taste or smell. That's not common not a common presenting symptom for a viral illness. In medicine, we do blame a lot of things on viruses without really, formally identifying the virus. I don't know, you can the history better than I do probably, Adam, but I think it was probably 10 or 12 years ago that these PCR panels and rapid tests became available. I remember thinking, oh, the future of medicine is here. Because we don't have to just blame things on rhinovirus or coronavirus. We can actually get a sample of a patient, send it off, and the next day we have the result. Here it is. You're sick. This is why you feel the way you do. You have this virus. Like I said, we blame a lot of things on viruses, and often when we're not sure what's going on with the patient, we'll say, it's probably just a virus, and if it is, in a week or two, you'll be feeling better, and we won't have anything to worry about. But it'll be interesting to see if we ever can figure out how this virus is causing those symptoms in that small percentage of patients. In the United States, we're starting to, they've put some reports out just this week about patients mostly from New York City and what symptoms they had and the percentages. But like I said, there's going to be a lot of information in the coming weeks to months. It'll be interesting to see where those symptoms fall out as far as how common they are.
Sure. Right. Right. So Another thing I've heard about is a productive cough versus a dry cough, right? So other viral infections and bacterial infections cause a productive cough, and this seems to cause a dry cough or a non-productive cough. So can you explain that a little bit?
And then early on, I read somewhere that the um, that in that second week, the patients would um, basically progress from a dry cough to a productive cough.
Okay.
And that made sense to me, because I thought that a lot of the patients that were having severe symptoms were probably due to secondary bacterial infections. You know, that's very common where you start off with a viral infection, you get some congestion. It can happen in the upper airway or the lower airway. You get some congestion in the chest, and that's the perfect place for bacteria to start growing. You get that secondary bacterial infection.
Right.
And I thought that that's what they were talking about with this, but I think that that's probably not right. I think it's probably has more to do with the course of the illness.
That makes sense.
Um,
I mean, that's also true for flu infections as well, if I'm not mistaken, that influenza can also cause, severe flu can cause these secondary bacterial infections. Because essentially what's going on is, the virus is replicating in the epithelium. Those are the cells that are producing the mucus, that are producing, so they have these little hair-like projections called cilia on them. And if those cells are dying because of the viral infection, that's the normal barrier, the normal way that we guard our, sort of respiratory tract from bacterial infections. We have this layer of mucus and we have these cilia, and it's kind of like a conveyor belt. If in a way, it keeps the bacteria flowing down, and we swallow them, and go into our stomach, get destroyed, that kind of thing. But if that mucus isn't there, if the cilia aren't those little hair-like projections aren't there, the bacteria can kind of get stuck there and start to grow where they're not supposed to, and so then you have these other complications. So it kind of makes sense that it could move from dry to potentially productive. Now in terms of the vent, people on a vent, so my understanding is that a lot of that's due, and maybe we can touch on this now. There's words like cytokine storm, or this idea of essentially an overactive immune response. And for some reason, in some people, it's this overactive immune response, this inflammatory response that is causing a lot of the severe disease. And I think maybe the next session of this, we can delve a little bit more into the immune aspects of this. But so essentially, they can exchange oxygen across their little tiny air sacs called alveoli in their lungs to essentially oxygenate their blood. Is that essentially what's going on, Josh?
that's what the theory was early on with this, and that's the typical issue. And so one of the concerns now is the difference between SARS from, like you said, classic SARS or
Yeah.
SARS-CoV-1 to this disease, which appears to be different. So what I've read from the intensive care doctors that are treating patients with this is that that those protocols aren't working. It's a different disease course. One of the theories, and I'd be interested if you can touch on this at all, or if you've heard much about it, but one of the things I've read is that some of those receptors are attaching to porphyrin in red blood cells, and it's somehow blocking the heme molecule, and it's interrupting oxygen transport for our red blood cells.
Interesting. Okay, so I've not seen papers about that yet. So I will try to look into that between now and our next session. What I've been doing is because it's obviously early in this pandemic, even though it feels like it's been forever because we're stuck at home or whatever. So there's not a lot of actually peer-reviewed published articles yet. But what I have been searching a lot through is this site called bioRxiv. So these are basically pre-prints. So they haven't gone through peer review. They're not actually in a journal yet, but people are just trying to get the information that they have out. So you have to take all of that with a grain of salt. I have not seen that particular thing. I'll look into that because that's interesting.
I'll
Um,
show you. I'll have to get that to you, Adam.
okay.
It was the more in-depth piece that I read about it was using some kind of modeling software from
Okay.
Europe. I don't know if it was Switzerland or Sweden, and they were showing the binding, how how the virus fits together.
Gotcha.
Um,
So
really
sort of like
more
hypothesis.
basic science stuff. Much
Right. No,
more.
that makes sense. No,
I
so
would
sort
like
of
you to
like,
explain it to me.
yeah, right. So they're basically like, there's this model or this hypothesis, and they're kind of extrapolating. Well, if it did that, then this could happen. No, that makes sense. Yeah, that makes sense. And that's a lot of what's going on right now is, looking at some early evidence and then extrapolating, and that's fine. People have to come up with models to test. But you're right. The disease course is sometimes similar to the classics, are sometimes different. And so it's sort of trying to figure out, well, why is it acting a little differently here and there? Um,
Yeah, they're seeing some specific, you hear about ground glass appearance um, on some of the imaging studies with CAT scans for these patients. And then there's also some nodular findings that they have with these patients.
and where would those
Some
be located?
just in the lung fields, the lower lung fields.
Is that a non-classical presentation of pneumonia?
You can see that type of appearance, but yes,
Okay.
it's seems to be a little more specific for this illness.
Right. So when a radiologist puts up an X-ray, um, what did they look for to say, oh yeah, you have pneumonia?
So they call them patchy infiltrates. Typically, you can have a lobar pneumonia where it covers the entire lobe of the lung, but more commonly you see just these areas where it's just of consolidations. So when you look at an X-ray, you can see some of the bronchi or bronchioles. You can also see some of the arteries and veins. But then you see these small patches or nodules that you shouldn't see.
Right.
Typically, when
Okay.
you
So
hear
normally it
nodule,
would be so normally the lung would look basically just full of air, right? It would be kind of light colored. You can't really see those like bronchioles and things like that. Is that what you're saying?
um, well, you can see some of them,
Okay.
but you shouldn't be able to see the lung tissue on the X-ray. But as you get those consolidations,
Right.
you'll see.
And that's primarily caused by immune cells coming to the lungs, correct?
Well, or that, like you said, the mucus
Okay.
that you get in there. So that should be, like you said, full of air. And once you get anything in there that has more density, you'll see it on the X-ray or
Okay.
more specifically on the CAT scan.
Okay.
We don't typically do CAT scans unless you're worried that there's a fluid collection in the lung. But there's, obviously with this disease, there's different things going on. Even even recently, I read some things about bedside ultrasound. We're using ultrasound in medicine a lot more, and and there were some descriptions about using ultrasound to try to pick up cases. There's been some description of picking up patients that are positive, even though they're asymptomatic. They're finding they've been able to identify some lung findings even before the symptoms develop, which I thought was pretty interesting because a lot of times the X-ray can lag with the pneumonia. A lot of times the patients are in the hospital, you can see evidence of pneumonia, and if you get an X-ray a week or two later, it actually looks worse, even though the patient's clinically recovered. And it can take a good month or two for those radiologic findings to go back to normal.
Okay. Interesting.
One other thing, Adam, they were, just to mention, and again, it'll be interesting to see what happens with all this, but as far as those ventilator treatments, there seems to be some differences in what those doctors can do early on in the course as opposed to later on. And again, that goes back to this is different from what the intensive care doctors and pulmonologists and respiratory therapists have been doing with the ventilators on typical patients. So they're trying to use, from what I'm reading, they're trying to use um, more gentle ventilation early on in the course, and so less pressures on the ventilators, or even ideally to not have the patients on the ventilator. But then as the disease progresses, then they have to be more aggressive with the ventilator, because you can get, obviously when you're forcing air into a lung that's not working very well, you can cause some damage that way.
Okay. Yeah. So maybe the last piece we can touch on here for this first session. So someone's on a ventilator. I've seen stats that have come out that about 50% or so of patients, if they're on a vent, about 50% won't make it, right? Because obviously at that point they're fairly severe, right? So a ventilator, is that essentially helping the person to breathe on their own because they've lost the ability to breathe on their own?
The ventilator's breathing for them. Yeah.
Right. So if someone has, say, fluid buildup, immune cells have come into the lung, it's hard to get that oxygen from the lung tissue to the bloodstream. Then how is the vent helping that patient? Like, that's something that I'm not quite clear about, right? Is it just trying to do the best that it can, right? I mean,
Well,
is there some way to get oxygen across? You know what I mean?
yes. So one of the issues, like I mentioned, I work with kids a lot, and so when I don't have to use a ventilator very often for patients, which is great. But I still do work in the nursery, and so sometimes we have babies that need that respiratory support. The thing about babies is that their chest wall is very pliable, so it's easy for them to move their chest wall, and that's why kids breathe. They breathe a lot faster when they're really, really little, and then as they grow, they eventually start to have a respiratory rate more like ours.
Mm-hmm.
So we're used to breathing 10, 15 breaths per minute. When a baby's first born, they can breathe 60 breaths per minute.
Oh, geez, wow.
Yeah. And actually anything less than 60 is normal, and and it's typically around 40 breaths per minute. If you and I tried to breathe 40 breaths per minute, we'd wear out.
Yeah, probably pass out.
Yes, yeah, pass out first.
Yeah.
So when you start to have that disruption with the ability to move oxygen from the lungs into the bloodstream, like you said, then you either have to take a bigger breath, or you have to breathe faster to make the exchange happen. So that shortness of breath that you hear these patients are having, shortness of breath, they're breathing fast. Well,
Okay.
they're going to wear out. So you can only keep that up for so long.
Okay.
And when you're doing that, you're breathing off more carbon dioxide. So your electrolytes are getting mixed up in your body, and then you start to have problems.
Okay. No, that makes sense.
Well.
And
So the ventilator basically normalizes that. So you can increase your oxygen level, so you're not just
okay.
breathing 21%.
Sure.
And then it's also forcing that air in with higher pressures, so that basically you're getting that pressure in that these patients can't do on their own they can't just take a big breath and feel better.
Because they're basically worn out. Yeah, that makes sense. And,
Now,
and
the other things that you may hear about is that once you get past that next level is called ECMO. So that's extracorporeal membrane oxygenation. So that's where they're actually taking blood out of the patient, exchanging carbon dioxide for oxygen, and then putting it back in. So that's that next step, and those are the patients that are really, really, really sick.
wow. Okay. And I'm glad you brought up the piece about the oxygenation, because like atmospheric air is about it's about 20% oxygen, right? So if you are giving them like 100% oxygen, you're basically increasing the concentration of oxygen, which I didn't think about initially. But yeah, you're just sort of increasing the chance the more oxygen's there to kind of help drive it across. So, okay, that makes sense. Great. Okay, so so for those of you who are not only viewing this but also made it to the end, we were trying to keep these, on the shorter side. So we're less than 40 minutes, which is good. Um, and so if you have any questions, we would love to receive email, right? So I think you can find us both on the website. For me, if you just go to the biology website, and you'll find my faculty page here with my email. Josh, is your email on the health center part of the website? Do you know?
Adam, I'm not honestly sure. We've actually been trying to update our website, so
Okay.
it's a
Okay.
little more user friendly. So we're trying to make some adjustments. So
Okay. That's something Albright's done over the last few years that has been nice. The website has gone a lot better, so we're still in the process. Yeah. So okay. So why don't people, if you have questions, just email me, and I'll compile them. We can discuss some questions at the beginning of the next session. So just email. It's ahertzberger@albright.edu. You can also find that under my faculty page on the biology website. Okay. So Josh, thanks for doing this with me. I didn't want to fly solo on this. That would just be awkward, and you know. Yeah. So we'll try to put one out next week as well. All right.
that sounds good. Thank you so much, Adam.
Yeah. Thank you.